we're going to learn more about to amplify your interventions, how to ramp up engagement and intensity post-stroke. And that will be with Dr. Jaime Haines. She's a physical therapist and Doctor of Science in Physical Therapist, and definitely a board-certified specialist in neurologic physical therapy. Dr. Haines is an associate professor in physical therapy department at Central Michigan University and teaches in neurologic curriculum. She received her Master's of Science in Physical Therapy from Grand Valley State University and Doctor of Science in PT from Auckland University. She is a board-certified neurologic clinical specialist through APTA and certified in 2005 and 2015. Dr. Jaime oversees neurologic physical therapy services at Hands for Health, a student-led pro bono clinic at CMU, and supervises students in the program's weekly exercise class for people with neurologic conditions. Her research interest includes health promotion for people with neurologic disorders. Thank you so much, Dr. Jaime. And our objective for today will be to examine the latest evidence for stroke recovery interventions to patient engagement and intensity, be exposed to innovative ways to integrate current research and identify one or two ideas to amplify interventions that we can use in our setting. All right, so excited to learn about stroke. I'm now in acute rehab. I was in home health for more than 8 years. Is it 8 years? More than 10 years. Since I came here in America, they sent me to home. And now
very good.
I have difficulty documentation. So let's go to acute. All right. So you have the floor, Dr. Jaime. Welcome.
Thank you. Can you hear me okay?
Yes, thank you.
Yes, awesome. Okay, I'm okay. I'm going to go ahead and share my screen. I'm going to optimize for sound and for video because we have some videos today. So let me share. All right. Does that look good to you?
Yes.
All right. Fantastic. I'm going to go back. Wonderful. So I'm so excited to be here, and thank you, Dr. Jenny, for letting me participate. I loved this last talk on virtual reality. I think that there's some great things. So thank you, Dr. Gaines, and I love the way that you're making your content accessible. So thank you for that. I do live in Michigan in the United States, and I'm really excited to be talking to people all over the world. So Dr. Jenny, thank you for that opportunity. So we're just going to get started. I feel a little uncomfortable because I'm not sure how many people will recognize this quote from a very popular movie in the United States back in the 80s. Maybe you'll know this or not. So if you read that quote, maybe in the chat, maybe you know where this movie came from. But talking about, that reminds me, Marty, you better not hook up to the amplifier. There's a slight possibility of overload. And yep, he'll keep that in mind. So anybody know what movie that is from? It is from Back to the Future.
Yeah, and everybody all knows.
Everybody knows. That's awesome. I think that's fantastic. So Back to the Future was a commercial success back in 1985. Makes me feel really old. I've been around a long time. $381 million to become the highest grossing film of 1985 worldwide. So great that we kind of start out with that hook, because today I want to talk about ways to really think about stroke management. And I'm going to give you 4 things to think about. I initially had a list of 10, but I thought this is only a 50-minute talk, and I really want to dive into 4 things that have really come up in the research about how to enhance engagement, because you're all doing really good work, but let's really be intentional about the things that we're doing. So that's what we're going to be talking about today, is thinking about 4 big tools that can ramp up. And really, it is about stroke, but you could apply any of these things to any of your clients, whether it's stroke or just your general geriatric patient who's falling. Dr. Gans had a lot of great examples. To give you a little bit of background, I love virtual reality, but I don't have access to it. And I don't know how many of you have access to it. It is expensive. You need centers usually. And I work in rural health. And so the information that I'm going to give you, I feel is really practical for any environment, things that you can do really without having a lot of equipment. So I'm excited about that. And the other thing I just want to let you know is that I've done a lot of international physical therapy service learning. And so I've been to many countries, Central America, over in Africa, and taken physical therapy students. And I just really appreciate the interventions that allow us to not need a lot of equipment. So hopefully today, for those of you living, where that might be a challenge, or that you have lots of equipment, that's great. But hopefully you'll find that this stuff is pretty applicable to any environment that you're working in. So I do have permission, my disclosures, I have permission to use all the videos. You're going to see some students, you're going to see some of the community members that we work with, some of the clients from our pro bono clinic. I don't receive any compensation for products that you might see in this video or for speaking today. So again, what we really want to do is look at 4 big kind of interventions or ways to amplify working with stroke, providing boosts. So what can I do to really get more out of my clients who might be low motivation or just not seeming very well engaged? And really, I hope that I give you something that you can use on Monday. And so I'll be asking for your input. What's one thing you learned today that you could actually go directly apply to on Monday? So here's my philosophy, and I really do treat my clients as athletes. And when we start thinking about our clients as athletes, we still use the FIT principles: frequency, intensity, timing, and using the athletic sense of how can I get my clients moving better, no matter what neurologic condition that they have. So when we start thinking about athletes, we just need to meet them where they're at, right? So our athlete may not be, this incredibly 90-year-old javelin thrower, but might be that person who can't even sit up on the edge of the bed after a stroke. But when we start thinking them as athletes, we start being able to use sports type of analogies. So that's kind of where I work with my clients. I want them to feel like they have some self-efficacy, that they have motivation, and they have autonomy. So the first tool we're going to talk about is something called the optimal theory. And I don't know, this was just brought to my attention about 5 years ago. So it's optimal conditions. And so the optimal theory was a huge systematic review that was published in 2016. And it really talked about, what does the research tell us that gets more motor output? When do we learn best from a motor standpoint? What conditions can we set up in which people do better just based on the environmental conditions? So when I learned about this, I really started changing how I approached treatment. So again, this can be used with any client that you have. So the optimal theory really stands for optimizing performance through intrinsic motivation and attention for learning. And it's nice that it fits the optimal slogan because it's easier to talk about. So again, this is a huge systematic review that looked at a bunch of literature. So in general, the optimal theory states that we want to provide the conditions for our clients that enhance expectancies, that we expect more out of our clients, that provide autonomy, because we all want choice and we all want control of our lives and what we do. And then thinking about promoting an external focus. And what they found through their literature is that it really enhances motor learning. They took people that didn't have these conditions and took people that did have these conditions, and the learning from a motor and cognitive standpoint, there was significant difference. So the optimal theory in a nutshell, and this is a diagram that comes right from their article, in a nutshell, basically says that there are two big things that really promote motor output and motor learning. One is motivation. And so out of motivation, we look at enhanced expectancies. And there's some things under there that we'll talk about, and autonomy. And so I'm going to be more motivated. You're going to be more motivated with your clients. Your clients are going to be more motivated if they have some choice in what they do. And if I can start believing that I can do what you're asking me to do as a physical therapist. I believe I can walk better. I believe I can walk faster. I believe I have better balance. So we're going to talk about how to do that. So that's the first piece, is motivation. The second one is attention. And this is something, I'm an old school therapist. And when I went to school, we were very particular. You need to dorsiflex your foot, flex your knee, step farther. We were very specific. Shift your weight to the left, shift your weight to the right. And what they found through this systematic review is that that is an internal focus of attention. And motor learning is actually sometimes not enhanced by using those kind of terms. So we're going to dig quickly into each of these. So that is the optimal theory in a nutshell. And then that circle talks about the output that happens and how performance improves when we employ these things. So really, what does this look like? So the first one is motivation. And it's the way we give feedback. And it goes into lots of detail, but this is the big take home, is that emphasizing successful trials. So not really saying anything when something doesn't go well. We all know when things don't go well. But if I lost my balance, or if I didn't get my arm up high enough, or I didn't do well on a specific, I look at the escalator trial that Dr. Haines had in his last talk, and that individual misstepped. And what optimal would say, you heard the therapist say, you stepped a little too far. The optimal theory says, don't really mention that. But when he does do better, say, that was a better step. You were closer to keeping your balance versus focusing on the negative. And so that's one big thing from the optimal theory, is feedback. Because I think sometimes we say, oh, you didn't do this well enough, or you didn't do this well enough, but just changing our language. My perception as a patient of the task difficulty matters. And so again, this goes back to, and I think we naturally do this as therapists, but really recognizing it's okay to start with an easier topic or an easier exercise, even though you know it's probably not super challenging for them. Let them get success, feel good about it, and then start to progress. Sometimes that's hard to decide exactly what's going to be easy or not. But what I've taught my students and what I've started doing is, let's pick a task they are going to be successful with. Once they're successful and not making errors, then let's go ahead and start challenging them a little bit at a time. You've had that client where I've misjudged what was going to be easy or hard, and it was so hard that they got defeated. Have we had those things happen? Yes, of course. And so I think that patient's going to do okay with that particular exercise. And then all of a sudden, they don't do well with it. And you can see the defeat on the face. So this is about picking the exercise, let them start easy and building, so they can say, you know what, all I'm going to do now is make you go a little bit faster, or I'm going to have you reach a little bit farther. And so they already have had success. They feel good about it. And now they have a better sense that I can do this. And so that is something else from this theory. The next one is conception of ability. So what I believe I can do matters. And this is actually influences motor output and motor performance more directly than anything else. And you've had those patients that, I can't do it. And you probably had those patients that say, you know what, I'm up for anything. So the people that have those malleable personalities where I'll try it, I'll see what I can do, those are the people that actually have better motor output and better performance. So when we think about the words that we use to promote more malleable, I'm willing to try some things, this is a learnable skill. You used to play football or soccer, you were an athlete before, or you had a really hard job working on the railroad. This should be really something you can learn. And so really changing the focus of how we talk to people. I always talk about my clients as athletes. You're an athlete. Don't you remember playing football? Do you remember this? Even if they weren't an athlete, you were a mom of 3 kids. You know, you did this, this, and this. certainly this is a trait that you can learn. This is a skill you can relearn. So even just changing our language. The next one from that motivation, so we talked about enhanced expectancies, and now we're talking about how to give autonomy to our clients. So this is about giving them choices, even when it doesn't make a difference on the treatment that you've chosen for them. So thinking about, it's not whether do you want to do therapy or not. That's not the choice we're talking about. We're talking about in therapy, today we need to work on balance and we need to work on strength. Which one would you like to start working with today? Or today, I have an idea of working on the treadmill or working outside on hills. What would you like to start with today? It could simply be giving choices about you're going to use some dots or some balls. What color ball would you like to use today? What particular ball do you want to use? You want to use the basketball? Do you want to use the baseball? What would you like to use today? And so just giving them some sense of control during treatment that really doesn't impact what we do. Things like, do you want to work in the hallway or would you like to work in the gym? Do you want to practice all three of these activities together or one at a time? Do you want to use your walker or would you like to try these walking poles? Do you want to try balancing on the foam first or balancing on the solid surface first? And so those are the kind of things that we want to ask. They're simple things to integrate into treatment that just gives someone a sense of control over versus, because again, I'm old school. We used to say, okay, we're going to do this and we're going to do this and we're going to do this and we're going to do them in this order. What they found is people who have more choices participate more and have more motivation. I think it also helps with our rapport. So even the timing of feedback, you know, you've got individuals you've probably worked with that just stop telling me, stop talking to me, stop saying so much. You can ask them what kind of feedback would they like. So Mr. Jones, I can give you feedback after every time you do this and tell you how you did, or you can do this 10 times and then I can let you know what I think, or I can ask you what you think. Sometimes, you know, we talk too much and we give too much feedback and that doesn't match with what the client wants or needs. So that's a simple way to build rapport, but really help them have some choices. Okay, so I gave a whole bunch of different language that you might try with your clients if you're still a little bit unsure. We're not going to go through those just for sake of time, but the words you do matter. So one of my favorite ones is, and I'm an I'm an assertive physical therapist. I know that our patients have to be challenged to get better. But I like the bullet number 3 where I say, you let me know when you're ready for an additional challenge for this exercise. So again, if I make it easy, you know, they can recognize I'm ready for a challenge, but they can kind of determine when they're ready for that next challenge. And again, that's an easy choice. So you can look through these, see if any of these might work for you just to start using that language. The last thing for the optimal theory is talking about attention. So where is the focus? So what do we mean by attention? The way that a patient monitors the task that you're asking them to do is part of the attention. Using physical and other cues, getting my attention. So when we work, I do a lot of work with Parkinson's, and there's a lack of attention to how they're moving. And so we use cues, to physical and other cues, to get them to pay attention to the movement. But the way the patient monitors the task is really, how are they paying attention to how they're moving? And then the ability to control that concentration. So again, you know, people who have short attention spans after stroke, they'll walk, and then if something comes up, they'll get distracted and their walking starts to deteriorate. So that's what we mean by attention. How does the patient pay attention to the movement that they're completing? So what they found, and what is so important to understand, is that when we internally help them focus, so when we have them focus on their body parts, they have to go back and use a lot of executive function a lot of conscious work to think about how much did I bend my elbow? How much did I dorsiflex my foot? How big of a step did I take? And that is a really slow process when I have to be conscious about it. But when we direct focus of attention away from the body and toward just the intended movement. So if it's walk 100 feet, then we say, I want you to walk 100 feet, and you let them walk. And you don't focus on, I want you to take this many steps. I want you to have, like when we focus on gait kinematics. Early on, it's good just to say, I want you to walk 100 feet. You walked 100 feet. That was great. What do you think you can do next time? Thinking about that kind of thing is just walk is a very unconscious, fast, reflexive feedback loop. And it kind of promotes that automatic movement. Another example would be if you're working on weight shifting, because people with stroke don't like to put weight on there. If you put some targets on the wall or something for them to externally focus. So instead of put more weight on your foot, oftentimes that doesn't work, or it's very short-lived, or it takes a lot of concentration. We may say, press against the ball on the wall, put your hip against the ball and make that ball squishy. Squish that ball against the wall. And that will get them to weight shift because they're looking outside of themselves. That's much faster. Squish the ball with your hip, and that promotes that weight shift. Or dots or targets. And so if you have some targets and you're asking people to reach, okay, if I put some targets on the wall and say, just reach to the target, by making that an automatic movement that's focused outside my body, if the target is far enough out, they're going to automatically weight shift. That reflex loop is so much faster. And what they found is that that enhances motor learning. So this idea of stop focusing on the specifics of the body part and looking outward to those larger targets and kind of the end performance. How did they do? I want you to take that boom whacker or take that hand, and I want you to hit it on that target. That is an external focus. So again, it really great stuff, just things that we can work on with everybody. So in summary, for this optimal theory, and it's a 20-some page document that you can look up that research, and they go into very, very big depths, but I felt this was the most clinically relevant things for our talk today. So the first one is autonomy, giving choices, and I gave some suggestions there on the screen. And then we have this idea of enhanced expectancies. You walked 100 feet. How much farther will you go the next time? I'm expecting you to walk farther than 100 feet. And I will tell you, that line right there has worked. Hey, do you think you can walk that next 100 feet quicker? I think you can. How fast do you think you can walk that next 100 feet? How much faster? I'm expecting you to do better. So that's a great line. And then this idea of external focus of control. So keep the tray level when you're walking. Don't spill the water when you're walking. Those kind of things. So that can be used with any client to enhance motor learning and engagement. So that's our first tool. Our second tool is aerobic training. How many of you have heard about aerobic training and the blessings that come from really getting into our target heart rate and promoting heart rate? Yeah, a lot of you, I can see the thumbs up. Thanks for that. But it can be difficult, right? We're often like, I don't have time to do aerobic training. So the first thing I want to let you know are some resources, because I'm not going to have a lot of time to talk about all these. But there is a campaign at the American Physical Therapy Association, and I don't know how many of you have access to that, but they've got this called Intensity Matters, and they've got so many tools to help you get better at monitoring heart rate. How do you calculate target heart rates? What if they're on medication? What does that mean? They've got all these tools. So I just want, if it's a scary thing to think about, I'm going to exercise my person who just had a stroke. Yeah, we need to be considering that. So I wanted to show you this resource and link that for you. So the first thing we need to do is really talk about aerobic training. And so what are the direct effects of when you do good aerobic exercise? So It floods the brain with brain-derived neurotropic factors. All these great factors flood the brain, which enhance things like the neurotransmitters, dopamine, serotonin, all increase when we do aerobic training. If you're any kind of exerciser, although we might have a love-hate relationship with it, we know generally when we aerobic exercise, we're in a better mood by the time we're done. Physically, we feel better. Mentally, we feel that sometimes the fog has cleared. So we see that its part has to do with those neurotransmitters that are now flooding the brain, the good ones. When the BDNF is flooding the brain, that means we are ready to learn. The brain is primed. So any new learning I want to do, I am ready for neurogenesis. I'm ready to create new connections. If we do aerobic training before we have a disease process, it's neuroprotective. So I'm in better condition to be protected should I get a neuro condition, Parkinson's, having a stroke, multiple sclerosis. So those are the direct effects, but then we look at the indirect effects and looking at physical fitness, so cardiovascular fitness, and we know worldwide our cardiovascular fitness is really poor. In Michigan, almost 60 to 70% of people are obese. They fit the morbidly obese category. And so our heart disease, we have heart disease centers everywhere in Michigan. We don't do a very good job of it. But we also see that aerobic exercise can reduce inflammation, improve cerebral blood flow, and then in the end, it all talks about better things for brain health. So we really should be considering this for our clients, especially for those direct effects. If I aerobically train and my brain is ready to learn something new for therapy, I should be aerobically training. But it can be scary. So the exercise recommendations for best practices after care stroke, they just did an update in 2019, and some of the things I want to share with you. The first one is we can and we should be using aerobic training. And this particular article talks about testing and monitoring. You always need to know where the patient is with aerobic testing. If they can get a submax exercise test through a physician, they should, or at least be getting some parameters from a doctor before you exercise them. If you're good at this, I've not done a lot of submax testing of people, so I get parameters from our physicians. If you don't get a parameter, then we need just permission to exercise, and we need to be monitoring very, very closely. Things like ways to test this, if you can't do the submax stress test, then there are things like doing a 6-minute walk test. That's something that's in our wheelhouse. Monitoring their vitals. First, their heart rate spikes. Okay, then their heart rate goes down, or what's going on with we can get a really good idea of what their response is during a 6-minute walk test. And then monitoring everything. If you're not monitoring, you need to be monitoring. A cheap pulse oximeter is better than nothing. A blood pressure cuff, heart rate monitor, something that helps you determine whether someone is in their safe zone. If they're on beta blockers or other heart meds, we use the RPE scale. And that's going to help us determine if we're working them correctly. There's some intensity work guidelines here. So if you're unsure, always start conservative. Start with that light intensity, see how they respond, and gradually work up. You're all incredibly talented therapists. So you need to use your clinical decision-making on how, where you're going to start, and then have that documented in a really good rationale. So I've given you some intensity work guidelines there. In my practice, we use a 1 to 10 RPE scale. The 6 to 20 is sometimes confusing for people. So I've given you both from this document. Looking at 0 to 10, moderate intensity, 4, 5, 6, vigorous intensity, that above 6 is what we're looking for. And then always monitoring RPE, because that will help the patient, something they can use at home when they are looking at their own exercising at home. They can start thinking about that at home. So how can we be intentional in therapy? So you're saying, like, I can't bill for a half hour aerobic intensity session at my clinic. And I will agree with you, that can be hard to do, or you have lots of things to work on. And so you don't want to spend your time just having someone work on heart rate, getting the heart rate and working in the intensity zone. So I have 3 things for you to think about being intentional about incorporating aerobic intensity. Okay, the first one is priming. So we're going to talk about these 3 things. So the first one is priming. So this idea that if I do aerobic training prior to an environment where I'm going to learn something new, which is all of our treatment sessions, right? That exercising for at least 20 to 30 minutes in moderate to vigorous, and I would say even some of the light intensity for some of our really sick patients, may induce neuroplastic changes in stroke that help learn better. And so our brain is ready to learn. I tell my students, you should be walking and getting your heart rate up before an exam, before a practical, before a big test, before anything. Our students just took the state boards in Michigan. That was on Tuesday. I emailed them all and said, you better be priming your brain before you go. So even performance. So if there's a way that you can talk your clients into doing something before they come in, even if it's a short walk, we need more studies. But right now, it's really looking like this is a positive thing for us. So priming ideas. So if you're uncomfortable doing it in the clinic because of the time that you have them walk or go on a bike, or can they come in early and do some non-billable ergonomic on the bike so they're getting their heart rate up? Even 10 minutes. Ideally, it said 20 to 30. Can they walk before they do their home exercise program? Can they come in and do a new step, or are they safe to walk on a treadmill? If not, then you don't want to do that. But these are just some ideas. You can bill for priming, but you've got to remember it's skilled. You can't be documenting or drinking a cup of coffee and not monitoring vitals. So if you wanted to do a 15-minute priming, aerobic priming, you can do that, but you've got to document correctly that this is what you're doing. Aerobic training for priming prior to motor learning. And you're looking at heart rate, intensity, you're looking at the target heart rate zone, you're looking at RPE, you're upping that challenge. That's how that can get documented and paid for. Now, will you be able to do that every time? Maybe not, depending on your client, but that's a way that you can do that. So those are some suggestions with that. Another one is functional, sorry, I got a bug in here, a functional circuit training. So how many of you have used circuits? If you use circuits, so let's say you have 3 things or 4 things, 4 activities that you want to work on. If you set up your treatment session, so instead of just always working on balance, and you do that for 15 minutes, and then you work on sit to stands or strengthening for 15 minutes, or walking for 15 minutes, consider putting those all together and making a circuit. This is a great way, and you can still control how intense they are. For your patients who aren't really good at this, you can give them plenty of rest time. It doesn't have to be intense. But this is one way to get people to increase heart rate while you're working on the things that you want to work on in your clinic. So thinking of, so what is a functional circuit training? And I do everything functional. Everything I do is geared toward function and task specificity. If you want to get better at transfers, you got to practice transfers. If you want to get better at walking, you got to practice walking. So a Cochrane review done in 2017, and Cochrane reviews are kind of like our gold standard. It looked at how circuit training improved walking endurance, balance confidence, fitness, and daily physical activity. Because if you think about what we do in a day, I don't just spend 15 minutes standing at my counter or a half an hour standing at my counter. And then, you know, a lot of times I'm walking into my counter, and then I'm going into the garage, and then I'm going to get my laundry, and then I'm coming back, and then I'm using the restroom. You know, it is a functional circuit. That's what we do in our daily lives. So to even just set up exercises where they're having to change position, think about a new activity. And then in the midst of that, hoping to get the heart rate elevated a little bit more, you're really killing a lot of birds with just that one stone. And circuit training was effective for improving walking after a stroke, regardless of time since stroke. That's huge. So consider how many of you can you string things together? So I gave you some ideas here. So here would be some examples. Some of these are mine and some of them came from these other 2 articles. But thinking about we all love sit to stands, right? Sit to stands. So I do sit to stands for 30 seconds. We're going to do that here in just a minute. 30 seconds of sit to stands, reaching overhead for 30 seconds to targets, because that's what the optimal theory says. And now I'm going to work on floor to stand transfers for 30 seconds or a minute, or I'm going to do 1 floor to stand transfer. And then you repeat that 3 or 4 times. Think about the reps, think about the specificity and the weight shifting that we're getting, and think about the function, and then getting that heart rate up. And so I've given you a couple different samples of how you might put things together to really get aerobic work. All right. The other way to think about this is high intensity interval training, and everybody panics about this one. So high intensity means aerobic high intensity. We're hitting that 70 to 80% peak heart rate. Not everybody can do that, and I recognize that. But what's a way that we can be intentional about intervals? So intervals, high intensity interval training is that we work really, really hard for a period, high intensity, high focus, and then we do something very, very low intensity, but we don't stop moving. And then we go back to that high intensity. Most of us hate that kind of exercise, but it can be fun. And so preliminary evidence suggests that for stroke, cardiorespiratory fitness, mobility post-stroke, that it can improve some aspects of that. The American College of Sports Medicine says start low and go slow with people, especially for those that we're working with disabilities or dysfunction. So an example might be, I want you to walk fast for 30 seconds and then walk slow and then walk fast. Aren't we all working on walking anyway? And we should be working on changing pace anyway for higher level people. How about someone who's lower? We're going to work hard, sit to stands for 30 seconds, and then you sit and do arm swings, or open and close, or do something, arm circles. And then we go back to sit to stands, and then we do arm circles. So if you think about your lower level people who don't have good cardiorespiratory fitness, you can put 2 exercises together and imagine the repetitions you would get in if you did this for 4 minutes, back and forth, then back and forth, then back and forth. Most people have not moved continuously after a stroke for 5 minutes. I'm sure you've seen that. Like they have to do something and then they rest. And so most people have not worked that hard or kept that active moving for those longer periods of time. And they need to do that for good function and quality of life. Here's another one, sidestepping. So sidestepping, maybe you use resisted bands, maybe you use a weighted vest, maybe nothing. And then I stand and do small marches in place. And then I go back to high intensity sidestepping, and then I do something lower. So you can combine anything you want. Someone who's lower level, you can do circuits in bed, rolling, bridging, scooting your butt side to side, but thinking about let's just keep going. Let's just keep going. Those are some other ideas. Okay. If you want to know where and what to pick, there's all these other things from that article that talked about various intensity parameters. So if you are looking for aerobic capacity work, so you're only looking at, you've got this high level person who just doesn't have endurance, look at how they set up their intervals. 4 minutes, working hard, 3 minutes, 1 to 3 minutes lower. Now, again, you're in charge of that. So that's pretty intimidating for most people, even me, thinking about working at 80 to 90%, 70 to 90%, working hard, that can be really intimidating. So you might adjust those parameters. If you want neuromotor intensity, so I'm just really working on thinking about movement and retraining something, you might do something 30-second bursts and then go 4 minutes light. So you might tweak this for someone who's just really early recovering. We're going to do hard work, and then we're just going to do something for a little bit longer. And then work hard, so you might adjust the high to low intensity. So short intervals are the ones that I tend to use because both my patients usually need both of those. So they recommend both for this aerobic intensity and neuromotor, and I think it's pretty feasible for clinical practice. And then you can justify using these words that you're doing interval 30-second bursts of effort with 30 seconds rest, or 30 and 45, or 1 minute and 30 seconds. In our high intensity interval class that we teach at CMU for people in the community, we do 1 minute high intensity, 30-minute rest, 1 minute high intensity, or sorry, 30-second rest, not 30 minutes. So just some ideas for you of how to really utilize HIIT training. Of course, we always have our contraindications and things we need to be careful of, so I put those in here. Watch for those hypotensive responses. Exercise dilates blood vessels. If your folks have cardiovascular disease, they're probably already on blood pressure meds, right, that are already lowering their, so when you now start to exercise them, they could even drop more. So monitoring is vital, is absolutely vital to know that you're keeping your client safe. Of course, hydration. And if your client is having difficulty, think about a seated recovery position. So if they get fatigued in their legs a lot, or they just feel exceptionally tired, have them up doing something and standing for that high intensity, sit them down for the rest recovery and doing something a little bit less taxing in a seated position. And of course, always monitoring. All right, I got to get through these. Tool number 3 is music. So we're just going to do this a little bit. So I want everyone to stand up. I can't see you, so I don't know if you're really doing this. So if I'm the only one doing it, I know you need a break and I know you need to exercise. So we are going to, I'm going to turn on the music. And what I want you to do is you can squat or sit to stand to the music, because this is going to be, yeah, someone's got a heart. So stand on up. We won't go through the whole song. I'm going to play this, but we're going to do some squats. And I want you to first think of the beat. Here we go. Ready? So down, up, down, up. So sit, stand, and feel that. Worth of work. My heart rate is going a little bit, but my point with this is we're going to talk about rhythmic auditory stimulation. And what I was supposed to do before was just to have you do some sit to stands without the music. But if you really thought about how the music drove your movement, right? There's some great things that are coming out about rhythmic. Yeah, I'm glad people liked it. Thank you for those. I see the icons coming up. Thinking about rhythmic auditory stimulation and how it drives movement. I don't know how many of you have used music in your practice, or metronomes, or the beats, and we're going to talk about that. But what they're finding is that any kind of rhythmic auditory stimulation has a positive effect on gait, helping me improve motor integration and balance after stroke. Now, while this meta-analysis says that, they recognize that they need more studies. But what they found is that it improves velocity, so the speed at which I walk, the step length, and my step cadence. And so I don't know how much people know about this, but we used to really think about metronomes. But I went to a conference, went to a session at our combined sections meeting on this phenomenal group that is working. He's a music therapist, a musician and a music therapist, and they've put together this great, I linked it here in the show notes, the lecture notes, and I gave Dr. Jenny permission to share my slides with you. So you can go to this website. We're going to watch a quick video. But what I want you to know, and what I learned about music just this winter, was that music is a distractor. And I think we would all agree, if you're working out, whether you're lifting or walking, we love to listen to our favorite music. There's something about that. Music has the ability to alter breathing and heart rate. So a lot of times we may be breathing. So if you think about music lowering the autonomic nervous system, and we use deep breathing in yoga and meditation, just as much as it can ramp up for exercise. Improve your state of mind. We all know if we listen to our favorite songs, we feel better. It reduces the perception of pain. They've done studies on that. It alters patterns of pain and depression. It occupies the mind with something that's familiar, especially if it's music we like. And so we get the good vibes in the brain. And then music, this is what we really use with auditory stimulation, is that music with a strong beat encourages the slow brain waves into meditative states. So if it's slower, we can reduce any high anxiety. If it's faster, I may be more focused. So I picked that song. It's one of my favorites. It's Uptown Funk, and it's got that do, 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 you know, that very, very distinct beat. And we can catch on to it really, really quick. And it gives us the feel good. So this comes from this website. So really recognizing all these things. I was supposed to hit my stars as we went around. Okay. But really, what is the physiology behind it? So really quickly, how can music or rhythmic auditory stimulation help retrain motor control? So what they've looked at is that the brain hears the space between whatever that beat is. And that signals and helps the body anticipate the next beat. And so I'm thinking about, when is that next beat coming? When is that next beat? So it's very subcortical. And then it facilitates the brain to anticipate, like, I need to take the next step. So a lot of times we're using rhythmic auditory stimulation during walking. We use this a lot in Parkinson's to help train the automatic movements they lose. It's an external cue for a lot of people. And remember, optimal theory said external focus. So if I simply said to you, and this is what we did in the beginning, do sit to stands to the beat, you're not thinking about, oh, I've got to contract harder, I've got to develop more power, I've got to go quicker. You're just automatically going to the beat. And that's what we mean by external focus. So this fits really well into the optimal theory that we talked about. And so the music and the beat helps the patient anticipate, I've got to take that next step. So I want to, so here's how you might use it. You might use it to facilitate a response with the music. So thinking about the speed of the beat. So you notice when we did our example, I had you go slow and up and down. And then I said double time. And now you're really increasing. You're still keeping to the beat, but you've increased that speed. So we think about speed. We think about the beat to increase power. What happens when I ask you to sit to stand quicker? You have to generate power. And we need to be training power for steps, climbing up a hill, carrying a heavy load, right? We should be doing that. So by asking you to increase your speed, I'm asking you to really work on power, because power is contraction of muscle over time. More power, the quicker you need to do something, the quicker you need to generate power over muscle contraction over a shorter period of time. So this is a really good way to train different ways to do sit to stand. Do you ever have to stand up quickly? Like to catch your grandchild, or to help someone, or someone's falling, or you got to stand up quick because there's a tree going to fall on you or something, right? You have to move quickly. So we should be training transfers and daily activities at different speeds. So this can be helpful. It can increase motivation and retrain someone who has apraxia, so problems with motor planning after stroke. in memory. So this is from MedRhythms, which is the company that is doing a lot of this research right now. I'm going to move forward here. I got to get to the part where we're talking about movement. So I want to just give you an example because I think it's powerful. Retrain movement, here it is. So we're just going to watch this really quick, an example. Oh, let me give you, So George underwent a stroke. Here's how he's walking before. He looks pretty typical.
Smiling.
He's smiling. Very motivated individual. You see his asymmetrical stepping. He looks pretty much like most of our stroke patients. Standing on one leg longer, less time on his affected side. They started a strumming, working with him on beats and guitar. But you could do this with your phone. Stop, stop, step, step, step. So you could see how he needs to try to step to that beat. Here's one treatment session. Different. Unbelievable. They were able to take away the music, which is what we eventually want to do. Look at that. One treatment session. So I'm not saying that, you know, that would be everything, but if you were to, so I'll tell you in just a minute how to pick that cadence and how to pick the music. But if something like that, the other thing that's coming into evidence is talking to yourself and singing to yourself. So singing internally, staying alive, you know, singing that in your head can also, the patient can also use that at home for cueing. So it's pretty impressive. So how do you go about figuring that out? Okay. So there's a free app called Metro Timer. That's the one that I tend to use. And so it's free. It's a free download. It has not only auditory, but it can be have a light to it. So it could be a visual stimulation if you've got someone who doesn't respond to the hearing. So what is your goal? So if your goal is to increase gait speed, all right, is your goal to improve cadence or stride length, you've really got to figure out what is my goal. A lot of times we're working on symmetry, but remember, when we talk about optimal ways to work this, we're not saying step longer, right? Or stay longer on your foot. That's an internal focus of control. This is all about external focus of control. So if you put the music on and just ask them to step to a rhythmic beat, they are going to have to equalize out their step length and stride lengths, right? They're going to have to if they're going to stay on that beat. So you don't need to focus internally. You just have them focus externally, which we know from that systematic review drives better motor learning. So what you will do is you will count their steps in a minute to get their cadence. So how many steps? So just let them walk for a minute, count their steps. And then what you want to do is you want to increase that number by 5 to 10%. So we want to push cadence. We want to push. So we want to find a song that matches the cadence that they had. So if they, if they walk 80 steps or around there, you want to pick a song that has that 85 beats per minute, 95. And if you just plug into Spotify songs that are 80 beats per minute, 90 beats per minute, you'll get quite a few that at least you can start with. So you don't even have to think about that. Eventually, the training time can be 25 minutes. That's probably enough for most of our folks to really work on that. And then they can use that information at home and practice walking at home if you think they're safe. But eventually you want to change those songs and tempos. You can do this for any activity. How about sit to stands? We all do the 30-second sit to stand test. How many sit to stands? I use that now more than the 5 times sit to stand. But if I want them to get more sit to stands in a minute or 30 seconds, now let's get the metronome and see if they can't keep up with that so it can drive behavior. All right, tool number 4, I'm kind of coming down to the wire here, is really thinking about overground training. Here is all the things we already know that look bad in stroke when it comes to walking. Step asymmetry, it's high expenditure, they get fewer steps, they don't walk as many bouts during the day, they don't have a lot of self-efficacy when it comes to balance and walking. And we all know the detriments is that limited participation. If I can't walk, I can't participate. If I can't participate, I'm isolated. If I'm isolated, I get depressed. We've all seen that. And then if I'm depressed, my quality of life is not good. So we know it's important. So here's all the evidence on all the things that we should be doing for stroke when we're thinking about overground training. It's not just about walking straight on level surfaces. So people who practice backward walking and stroke. Backward walking is now a better predictor. The 3-meter backward test is now a better predictor of fall risk than even the tug or gait speed. And so we need to be working on backward walking. Multi-directional stepping improves self-efficacy. Dual task with walking. And that was one thing I had to leave out this time is dual task, but improving doing motor 2 things at once, a cognitive task while I'm walking. Those things are all things that can improve self-efficacy, falls, and just overall confidence. Task-specific circuit training. We've already talked about circuit training. You can do circuit training with walking. So pick some walking at sidestepping for 30 steps, backward walking for 30 steps, back to side stepping, wide walking, monster walks, sidestepping with a tray table. Like you can use all of your gait training ideas and put that into a circuit as well. And then the big one is this reactive perturbation balance training. And so it's very hard to train reactive balance safely. So if you have a harness system, that's the best thing you can do is to train reactive balance. If you don't have that, I've got some other ideas for you, but reactive balance training is what prevents falls, not anticipatory usually, but it's reactive. So we need to start concentrating on reactive balance, which is very scary to train. There's a reason we haven't been training it as therapists. So here's a whole bunch of ideas for you about how to really think about your obstacle course or the overground training kind of things that you're doing. I'm going to focus on the reactive balance for this last minute here. Waist pulls, hidden obstacles, unexpected perturbation. So when we mean waist pulls, we're putting a TheraBand. And as someone's walking, we're pulling that TheraBand around their waist. So they've kind of got to react to that. Again, always want our patients safe. So here's some really great ideas, you know, about overground training, but I'm just asking you to be really intentional. Are you using the latest evidence to really retrain what people need to get back into the community? In my community, people are working on farms. They're working on gravel roads. They're having to walk out to their mailbox, which is 150 yards, and they've got dogs barking at them. So I've got to really consider what is it that they're going to be, the context with which they're going to be walking. Again, lots of ideas. Here's some very specific ideas that I've given for you that we've put together in obstacle course work. And I know some of them you may not know, so you can email me, but if you have any questions there, just to get you started, because I really want to make this easy for you. Lots more ideas here. I don't know, Dr. Jenny, do I have time to show my video or do I need to really be done?
Yes, please keep.
Okay. Keep going? Okay. So here's a video of my students working with some clients, and then I have some student demos. But I just want to show you some very deliberate things that we're doing here. This is Al. Al is a hiker. He's 85 some years old, and he hikes with his family up north. And so after his stroke, you can see his left side's a little bit weaker, but he really wanted to work on getting those poles back out. So the students gave him a backpack and his walking sticks. And right now they've set it up that he's got to walk through those trees. And you'll see here, he tips one over, but he recognizes it. There's his face, but look at the smile versus just,
slow down,
oh.
slow down.
Here's Mary. We're not going to watch this whole thing. Mary is obviously, let me get my volume here. Mary is obviously very high level, but the student, she was worried about turns and carrying things. And you can see, look at her beautiful pivot. And so this is back and forth. They did this, I don't know how many times. She had to set up all the boom whackers in a row. She wanted to work on fine motor as well. She's got a squat. She's got a balance. She pivots here. The student's really worried, got hand on the belt. But they must have done this back and forth 20 different times because she also had poor energy. And so this is all very documentable back and forth. So something there, let me go ahead here a little bit because they're going, okay. So here is an example of doing kind of a walking circuit that's not just walking. So they're going up and down, they've added some cognition. You've got to I'm going to call out numbers and you've got to find them. So I'm going to go back a little bit here. So this is, again, it's a circuit. The first part of the circuit is forward and backward walking with some cognitive. I've got to scan for the numbers. She's sidestepping, she's backward walking. They did this with their client and I just wanted her to repeat that. Obviously, she's finding those numbers, all sorts of ways you can do this backward. See, she's looking, look at the sidestepping she's doing. And then we love these tidal tanks. If you haven't seen these, they're water, they're very reactive. She's doing some lunging. And then she actually gets down on the floor, which is part of obstacle course training and overground if I fall. So having her do some mobility on the floor, she gets back up and she would have her client do this circuit like 5 times in a row. This is obviously a gentleman. He's young. He's in his 50s who's had a stroke. You can see the AFO. Ideally, I do this on a harness, but this is called a hidden obstacle course. And you can see how terrified he is. He's got his hand behind holding on to the therapist. But basically, you're walking over things that you can't see. So this is a great way to work reactive balance. So that was one part of this overground training because he worked in the woods. He was a construction worker, owned his business. So again, now we're changing it. He's got to step up. He's got to step down. He's sidestepping in very narrow spots because he would fall over with wood on the floor. He was in the woods, cutting down trees, that kind of stuff. And he said that was a lot of work in so many words. Here is him. He's working on endurance and really dynamic. He's a Lions football fan. I'll never understand why, but he loved football. So the students worked with him in just putting obstacles in his way. Sometimes he stepped on them, but trying to take away his focus and keep his balance while they're playing getaway. Again, this was his favorite thing to do, was really trying to go after these guys. And when you see his face, he loves it. Here's some ideas for changing surfaces, doing some weighted squats, walking narrow, picking up things from the floor. This is a friction reducer. So again, that hidden obstacle where I've got to manage myself. I know it's really fast. Transfers, this is one of my favorite ones, getting up and transferring in different directions. They're going to do a really cool thing here with the wedges. If you have any, stepping on wedges side to side, that's reactive. It kind of pushes you back. I know you'd have to tweak this for some of your clients, but just these ideas. We love boom whackers, stepping over, reaching, doing something with the arms, backward stepping. So again, just like you can do creative things with your overground training and mixing it up like this, you determine the feedback, you determine what needs to happen, but just wanted to show like this looks like fun. I think people don't know they're doing therapy. So we think that would help engagement. Okay, so in summary, we talked about 4 tools. The optimal theory, which was all about setting up the environment and the way we talk and the way we give autonomy and enhanced expectancies. We talked about aerobic exercise, talked about music, and then talked about the evidence for overground training. If we have time, Dr. Jenny, I don't know if you want to get on your phone and do this quick poll. I'd love to know what's one thing that you think you could use on Monday. I'm probably over my time, Dr. Jenny, but so if we have time, great. If not, you let me know.
Yeah. So thank you so much,
Okay.
Dr. Jaime.
All right.
I think, do you think we can have access also on those videos?
Yeah, yes.
In
I
the
think we can do that.
PowerPoint that
Yes,
you
yep.
gave us? Okay,
Yes,
good.
absolutely. Yes.
So we run out of time for the questions, but definitely
I'm so
we can have
sorry.
those are wonderful videos. So I really enjoyed as well. I keep putting my notes. I even put on the chat, Dr. Jaime.
Oh, I lost you. Hold on, Dr. Jenny. Why can't I hear you anymore?
No, it's my fault.
Oh, okay.
I am on mute. I keep talking.
It's my fault. So, okay.
No, I said that it's really awesome. Even Fretchy said that that's an excellent presentation.
Thank you.
Even put on the chat the Clock Yourself app about the dynamic gait training for
Yes.
those like endurance that they can add on. So I'm sure definitely we will put this on Monday. Do you have 1 or 2 questions, guys, that we can ask? But Dr. Jaime, can you put your email on the
Yes.
chat box? Definitely
Absolutely.
they will going to ask more questions. And this is new to me, the Metro Timer. I'm using the metronome, but I don't know the Metro Timer is more like colorful and more have a different beat. So that's really awesome. So if we have definitely we can chat more, but those are wonderful videos. And I think I have a question a while ago that I
Okay.
write this here. But definitely we can add it on as well. All right. So those are really excellent. Thank you, guys. Yes.
Yes, thank you. I'm glad you got a lot out of it. I'm sorry I didn't have time for questions. I tried to make it as short as possible. So
Yes, I really learned a lot. So these are
Okay.
wonderful videos, and we really appreciate those wonderful resources and examples. We appreciate you, and we would like to give the certificate of appreciation, Dr. Jaime Haines, for sharing your knowledge and expertise as one of the speakers of Geriatric Rehab Summit 2023, our 4th annual event. And this certificate was given on July 29, 2023 here in Delaware. In
Thank
front
you.
of everybody, we have awesome Dimitri from London. We have lots of physical therapists internationally, and we learned a lot.
I can't wait to hear what you've done. So let me know.
This Monday, I think I didn't know it's circuit training already what I'm doing, but I think I need to add more on that HIIT because I didn't use that up. I think my question is the RPE. Like, what is the great verbiage? Like, to ask them what is.
Yeah, I will show a picture. So there are some pictures out there, and that's so there's like from 1 to 10. 1, you're sitting on the couch eating bonbons or your treat, your chocolate ice cream. 10 is you can't talk and work at the same time. And we want you really working 5, 6, 7, 8. For most people, that's between moderate and high intensity. And so that's, and I said, so I want to, where are you? And I might not even use the word RPE, but I want your number. And that's what we say in our exercise. I want your number. So what is your number? We want you here. Where are you? And then using kind of the 1 is bonbons sitting on the couch. 10, you just can't talk and do anything anymore. You're about ready. You're spent. And then finding that happy medium.
Yes, I think our goal is around that 6, 7, 8. Okay.
Yes. And if you have a picture, you can have a picture. They have pictures with faces, with colors, and they can just point.
Okay, that's easier.
Yeah.
All right. Thank you.
You're
And
welcome.
now we have just ask question on the chat, guys, if you have any questions so we can see. Thank you once again, Dr. Jaime.